Thank you, Saurabh, for this wonderful opportunity to discuss EDOPS. I know this was a last-minute inclusion course, but I think a well decided course. This is the need of the day and the hour, okay? So I'm going to share with you my little experience with the Vivity, which I've been using for some time. It principally uses X-wave technology in which instead of splitting light, as you see in diffractive IOLs, it causes a stretch of the focus so that one is able to see things from distance to intermediate to almost functional near. Now, there is complete utilization of light and no light is lost when you use this particular EDOF lens. Hence, the lens provides excellent contrast sensitivity and the patient can see very well even in dim light. The visual disturbances are no more than an ordinary monofocal. And it's a forgiving IOL, and this is a very important point. It's a very forgiving IOL in case of inability to achieve emetropia, especially when you have those cases of the hyper mature intumescent cataracts where it's difficult to get an exact IOL power. The only thing, as Nitin said, that in all these EDOF lenses, the patients need to be counseled regarding the need to wear low ad reading lens. So now I'll just play a small video which explains the mechanism. I thought the video explains it better than I can. Volume. Volume.
This video on the mechanism of action of the Acrosoft IQ Vivity IOL.
Volume.
The Acrosoft IQ Vivity IOL
Okay, I'll
is
go
a
on.
first of its kind, non-diffractive presbyopia correcting IOL that utilizes X-wave technology to stretch and shift the wavefront. Acrosoft Vivity IOL utilizes essentially all light energy, giving patients an extended focal range with a monofocal visual disturbance profile. The Acrosoft Vivity IOL's X-wave technology consists of two smooth surface transition elements in the central 2.2 millimeters of the IOL. The first surface transition element is a slightly elevated smooth plateau that is about 1 micron in height, and the second surface transition element is a slight curvature change.
In this region.
With presbyopia, the focused light falls behind rather than on the retina when looking at close and intermediate objects. The slightly elevated smooth plateau is responsible for stretching the focal range. The small curvature change is responsible for shifting the continuous extended focal range to the anterior side of the retina so that a full range of vision is provided to the patient. The two smooth surface transition elements work simultaneously to stretch and shift the wavefront, creating an extended focal range, providing 20/20 at far, greater than 20/25 at intermediate, and 20/32 at close distances.
Okay, so basically there are certain factors we have to remember. There are many ocular factors which make it impossible to implant any of the trifocal lenses. So what are those ocular factors which are forgiving in case of this lens? Dry eye and ocular surface disease, patients with mild glaucoma and macular disease such as a grade 1 or a 2 ERM, unilateral cataracts. It's a great lens for unilateral cataracts, especially in young pre-presbyopic age group patients. When the patient has a monofocal IOL in the other eye and desires a little better range of vision, post-keratorefractive surgery, and I'm going to show you at least 3 examples of those, and minor inaccuracies in biometry, as I mentioned earlier, when it's not possible to get an accurate biometry. Now, there are certain patient factors which are not contraindications to Vivity. So your demanding patients, your type A personalities, those who are fearsome of reported nighttime visual disturbances, those who are habitual night drivers by profession, and those who work in dimly light environments. When you should not put a Vivity? You should not put a Vivity in patients who desire prolonged close vision, where monovision or mini monovision may not be adequate, where there is a severe loss of central vision, and when there is significant zonular laxity. So now I'll share my brief clinical experience. I must confess that I don't have the large volume that many of our esteemed colleagues on the dais have, but I started implanting this lens from the 30th of Jan 2021 in the midst of COVID. It was very slow initially because we didn't have the toric model. So far we've implanted 81 IOLs till the end of April, till 30th April. So we have got a range of follow-up from 1 month to 16 months. So there were 53 lenses implanted in 2021, out of which 22 were bilateral and 9 were unilateral. And in the first 4 months of this year, we have put in 8 bilateral lenses and 12 uniocular lenses for a total of 81 lenses. And if you look at the distribution of the torics to the non-torics, you can see that we implanted 45 torics as compared to 36 non-torics, which emphasizes the need that in all cases of multifocal or extended depth of focus lenses, you need to address the astigmatism very, very carefully. You must remember these are aspheric IOLs, so even a small amount of residual astigmatism in any aspheric IOL is not forgiving because it highlights the higher order aberrations that patients may have. If you look at the gender distribution, there are 55% females as compared to 45% males. I would have thought that more males would take this, but yes, like all trifocals, the females are a little more, at least in my group of patients. Now, these are the results of the uncorrected visual acuity at all distances. And as you can see, that as far as the uncorrected distance visual acuity is concerned, 2020 was achieved in almost 87.5% of patients. 2020 for intermediate was achieved in about 75% of patients. And if you combine the 20 and 25, if you combine the intermediate and the distance, it goes well past the 95%. And if you correct the distance, like if you do the best distance corrected visual acuity at all distance, the combination of the intermediate and the near goes almost to 97, 98%. Now, these are all carefully selected cases. There were no really ocular comorbidities which might have caused any degradation of vision. So the results have been extremely good and we've been extremely satisfied. Our patients have been extremely satisfied. And when you get something like 95%, you feel so confident of this lens that you can almost implant it in anybody. Now, there are some cases that I thought I'd discuss with you. This is my very first patient. He was a 60-year-old business.
Can you sum it up in 1 minute?
Yeah, so I think we'll go to the cases later if you want. Yeah. Just to sum it up.
Maybe you can highlight one case. So
I'll highlight this particular case because this is a case which will be, this is a case which is very interesting because it is close to our heart. This is a 52-year-old phaco and refractive ophthalmic surgeon. He had myopic LASIK in 2009 for minus 8.5 diopters, approximately. His pre-op best corrected vision was 6.9 in the right eye, N6, and 6.12 N6 partial with minus 3 and minus 3.75 diopter, respectively. He had a grade 2 nuclear sclerosis in both eyes. Obviously, being such a well-read surgeon, he didn't want a trifocal or a monofocal also. I offered him a monofocal. I insisted, but he said, no, I would like to go for the Vivity. That's why I've come to you. So the uncorrected visual acuity in the right eye was 20/30. This eye was the second eye. He chose to have a myopic overcorrection of minus 0.75. I was telling him minus 0.4 is what I'll go for, but he insisted I want a minus 0.75 since I want to read. His left eye, he achieved 20/20 vision. Binocularly, he was 20/20, both with uncorrected and best corrected. His visual acuity in the right eye showed a refractive error of minus 0.75. With minus 0.75, he was 20/20. Important part was that his uncorrected and as well as best corrected intermediate visual acuity is 20/20. He's operating every day. He's driving every day. His only problem is that he can't read so well. He's very fond of reading newspapers and he's a voracious reader. So while he reads most of his books on his iPad and things like that, as far as near vision is concerned, intermediate, he takes an addition of 1.25 despite doing the minus 0.75 in the right eye. But he's doing quite well. And his near vision is 20/20 partial in that particular eye with unaided. So he's very happy, and he's one of us, a guy who does LASIK and phaco surgery every day, and that's the little thing that I wanted to highlight. So in summary, it provides excellent distance and intermediate vision with functional near vision. Trifocals, though, provide better uniocular near vision as compared to the Vivity, and Vivity visual disturbance profile is better than the trifocals and similar to monofocal IOLs, and so it can be considered for the demanding patient. Those desirous of spectacle independence and unsuitable for trifocals can now be considered for the Vivity with some adjustment for monovision. And if cost were not a consideration, I think the Vivity could replace all monofocals going forward. Thank you so much.